The interpretation of the results of a pap smear test. It would be nice if the results of the pap smear test were something like, yes, cervical neoplasia is present. Unfortunately, it's not so simple, and there's a range of results you can get, and you have to know what they all mean. One potential finding on a pap smear is the presence of atypical glandular cells. This means that the test identified glandular epithelial cells, and the word glandular is key. If you look at this picture on the screen, remember that the outer portion of the cervix here, the ectocervix, contains squamous epithelial cells. So if you're seeing atypical glandular cells, they did not come from the ectocervix here. There's two possibilities for where they came from. One is the endocervix, which is what lines the cervical canal towards the uterus. The other possibility is there are glandular cells in the endometrium, so atypical glandular cells can also be from the endometrium in the uterus. Because these cells are atypical, they may represent malignancy, so this result of atypical glandular cells in a pap smear has to be followed up with additional testing. It's often followed up with a colposcopy, which we'll talk about in a minute, and when you do this, you need to sample the endocervix with a curettage. That means you need to scrape some endocervical cells from the cervical canal to examine them and to see if they are malignant. In addition to endocervical sampling, the glandular cells could also have come from the endometrium. So if women are age 35 or over and they have endometrial cancer risk factors, then this finding on pap smear is an indication for an endometrial biopsy. I talk about endometrial cancer in the video on uterine cancer, but the key point here is that sometimes women with endometrial cancer are identified through pap smear, and the way this happens is that you find atypical glandular cells on the pap smear. Another potential finding on pap smear is the presence of benign appearing endometrial cells. This means that endometrial glandular cells were identified, but they are benign appearing and not atypical. This is a very common and benign finding in women under 45 years of age, and for this reason, this finding will only be reported by pathologists on pap smear in women who are age 45 or greater. The reason it's reported in this age group is because there's a small chance it indicates endometrial cancer. What you do for follow-up of this finding on a pap smear depends on a woman's menopausal status. In women who are premenopausal, usually no further workup is necessary unless the woman has abnormal uterine bleeding or a high risk of endometrial cancer. In women who are postmenopausal, however, when you have this finding on pap smear, it's usually followed up with a hysteroscopy and an endometrial biopsy to exclude endometrial carcinoma. Besides atypical glandular cells and endometrial cells, there are lots of squamous cell abnormalities that you can detect with a pap smear. Remember, the goal of the pap smear is to detect squamous cell carcinoma, the most common form of cervical cancer. The most benign form of squamous cell abnormality is called an atypical squamous cell. There's a subtype called atypical squamous cell US, which means atypical squamous cells of undetermined significance. There's also a subtype ASCH, which means cannot exclude high-grade squamous intraepithelial lesion. And then beyond atypical squamous cells, you can see cells consistent with low-grade squamous intraepithelial lesions or high-grade squamous intraepithelial lesions. And when women have these findings on pap smear, this always indicates potential cervical neoplasia. What you do next depends to some degree on the woman's age and HPV testing if available, but in general, high-risk findings are always followed up with colposcopy. Sometimes if a woman is young and her HPV testing is negative and it's a low-risk finding like ASCUS, it's not necessarily followed up with colposcopy, but in general, most women who have these abnormal pap smears get a colposcopy to exclude cervical neoplasia. So that's a nice segue into the follow-up testing for abnormal pap smears. The standard test is colposcopy with biopsy. This involves using a colposcope, which is a fancy magnifying glass. It allows you to get an illuminated, magnified view of the cervix. This is usually done after an abnormal pap smear, or sometimes it's done in women who have abnormal findings on pelvic exam that suggest a possible cervical lesion. When you do a colposcopy, the cervix is washed with acetic acid. It will make neoplastic cells appear white. And so if you look at this drawing on the screen here, this is what cervical neoplasia can look like. You can see these white plaques. The thicker the white area, the more advanced the lesion is. During a colposcopy, areas consistent with dysplasia are biopsied. So this includes areas where the epithelium appears white after applying acetic acid. Also areas where you see a funny vascular pattern. If there's an abnormal or mosaic vascular pattern to the cervix, that can indicate neoplasia. Also any punctate or satellite lesions, which basically means any isolated areas where the cervix appears abnormal. Any of these findings can indicate neoplasia and should lead to a biopsy of those areas. And then it's high yield to know that you must visualize the entire squamocolumnar junction for a colposcopy to be considered satisfactory. If you don't see the entire junction, then it's an inadequate colposcopy. Remember, most cervical cancers occur at the squamocolumnar junction, and so if you don't visualize it, what that means is that the junction is in the cervical canal beyond where you can see with your eyes. So when you're unable to visualize the squamocolumnar junction like what's shown on the slide, then what you have to do is take a sample of the endocervix, the cells that are within the cervical canal. This is done through a procedure called endocervical curettage. And the idea here is that the junction is inside the cervical canal, so you take a sample of those cells because that's where you want to look for evidence of malignancy. Okay, so now we've talked about how you can do screening with a Pap test, and we've also talked about how abnormal Pap tests are followed up with colposcopy and biopsy. Well, what if the biopsy shows evidence of cervical neoplasia? Let's talk about the management of that now. First of all, it's super high yield to know that all patients who have an abnormal cervical biopsy should receive the HPV vaccination. The presence of LSIL or HSIL are not contraindications to vaccination, and there is evidence that vaccination may prevent progression to cervical carcinoma. Beyond vaccination, what you do next depends on the severity of the lesion. For low-grade squamous intraepithelial lesions or CIN1 lesions, usually these are managed through observation. 1 year later, you can repeat the colposcopy and also the HPV testing, and the idea is that these low-grade lesions, some of them will clear within a year, and the lesion may regress. If the follow-up colposcopy shows persistent abnormalities, then you can perform a conization, which we'll talk about in a second. If the biopsy shows a high-grade squamous intraepithelial lesion, a CIN2 or 3 lesion, then this is usually followed with cervical conization. This is a surgical procedure where a cone-shaped portion of the cervix is removed, and the idea is to excise the entire transformation zone, which is the zone where the cervical neoplasia is usually contained. This is both diagnostic and therapeutic. It's diagnostic because you can see the full extent of the lesion to see if it's more advanced than what the biopsy suggested, and it's also therapeutic because hopefully you remove all the neoplastic tissue. This usually requires general anesthesia, and there are a couple of ways it can be done. One is through electrocautery, which involves using an electrical knife technique called a loop electrosurgical excision procedure, or a LEEP. The other option is to use a scalpel. This is called a cold knife biopsy. There are also ways to do this using a laser. After a woman has had a conization, there are some potential complications, and it's high yield to know about these. First of all, the cervical canal can become narrowed. This is called cervical stenosis. So if you look at this drawing, if this canal becomes narrowed, then menstrual flow cannot proceed out of the uterus, and this can lead to dysmenorrhea. Also, after a conization, women can have cervical insufficiency, which can lead to problems in pregnancy, including preterm birth, and I talk about this in the obstetrics section. After a woman has had conization, the follow-up is usually testing at 6 months. Ideally, you test for HPV if it's available. If not, you can do a Pap test. But the idea is that the testing should be negative after treatment because you've removed all the tissue that was infected with HPV and that was neoplastic. So this slide just summarizes the progression of testing in cervical cancer workup. Make sure you have this algorithm straight in your mind. It comes up on rotations and boards. So screening is done with the Pap test or the HPV test or the co-test. If that's abnormal, it's followed up with colposcopy and biopsy, and if you have evidence of a high-grade lesion, that's followed up with conization. If the biopsy or the conization shows evidence of cervical carcinoma, meaning malignant cells that have broken through the basement membrane, then the management begins with staging using CT scan or PET scanning to determine the spread of the tumor. The treatment is based on the stage of the tumor, which is determined by the amount of local spread and metastases, and the treatment can involve surgery, chemotherapy, or radiation. We do screen for cervical cancer during pregnancy, and the screening indications are the same as in non-pregnant women. So if a woman presents for evaluation of pregnancy and she has not had a Pap smear or an HPV test in several years, she should get that test because you want to know if she has evidence of cervical cancer as you manage the pregnancy. Abnormal screening tests are followed up with colposcopy, but a biopsy is done only if the lesion appears high grade. So if the lesion has findings like raised thickened masses or ulcerative lesions, and these suggest a high grade cervical lesion, then you would perform a biopsy. Otherwise, biopsy is not done because it could put the pregnancy at risk. And then beyond biopsy, excision with conization is only done if invasive disease is identified. Otherwise, you monitor the woman throughout pregnancy and do further evaluation and testing after the baby has been delivered. And then I'll finish with one slide on the HPV vaccine. I talk about this in detail in the video on vaccination in the pediatric section. So there has been a 9-valent vaccine available in the US since 2016. It's called 9-valent because it protects against 9 subtypes of HPV, including all of those listed here, and this includes type 16 and 18, which are the 2 most dangerous types. According to the guidelines of the Advisory Committee on Immunization Practices, children should receive the HPV vaccine at ages 11 to 12 years. It's a stronger recommendation, a 1A recommendation for females, but there's also a 1B recommendation for males because HPV infection can occur in men as well. And then this is a nitpicky detail, but it's super high yield to know this for your shelf exams. If you start the HPV vaccination protocol before 15 years of age, it requires 2 dosages, one at time 0 and a second dose at 6 to 12 months later. If, however, you start the vaccination protocol after 15 years, then it requires 3 dosages, one at time 0, another at time 2 months, and another at 6 months. And there are many women who present for HPV vaccination after age 15, for example, when they've become sexually active at an older age, and so it's high yield to know that in that situation, after 15 years of age, HPV vaccination requires 3 doses. And that concludes our module on cervical cancer.